everybody. Thanks for joining us tonight. My name is Amber, and I'm with Project Opioid, and thank you for joining us for Project Opioid's Solution to the Opioid Crisis webinar series. Tonight, we'll be talking about what you need to know about opioids, addiction, and mental health, so we can heal our communities, our friends and family suffering with substance abuse and mental health post-COVID-19. So again, my name is Amber Addario, and I'm the Director of Harm Reduction Outreach for Project Opioid. So my job is to come to you where you live, work, and worship, and provide you with the necessary resources to reduce harm in the opioid crisis. And this can be a multitude of things, which I'll talk a little bit about later. But, oops, I overclicked. First, let me tell you a little bit more about Project Opioid. We are a coalition of community leaders, business leaders, faith, philanthropic, law enforcement, who are being brought to the table on this important issue to use their time, talent, and treasure and influence to really make positive, sustainable change on the opioid crisis. We started in Central Florida, where we're shooting this webinar out of tonight. But we've recently started coalitions in Jacksonville, West Palm Beach, Fort Lauderdale, Miami, and Tampa Bay. So please reach out to your local Project Opioid Coalition for more information. COVID-19 caused a tremendous surge in overdoses. In the state of Florida and in many communities, we've seen as much as a 40% increase in overdose deaths since 2019. That is the largest increase we've seen after a multiple year reduction in overdose deaths. And now with fentanyl, the rules have changed. It doesn't matter if you are an opioid user anymore. We'll talk a little bit more about that too. Before we begin, I want to take a moment and thank our partners that made this webinar series possible. Located in North Florida, we have LSF Health Systems. In Central Florida, we have Central Florida Cares Health System. And located in Southeast Florida, we have Southeast Florida Behavioral Health Network. These organizations exist to bring resources to individuals who need help on substance abuse, mental health, and a variety of other things. So please, I urge you to seek out to them if you need help in any way. And again, one more time before we begin, I want to remind you guys that there are 9 amazing webinars in this series. We have 2 more coming up. And I would urge you to check out our website, take a look at the content, and register to come back and join us for another webinar. So tonight, for our webinar, we have 2 amazing speakers. We have Dr. Wohl, who is actually the medical director for Project Opioid, and an emergency physician at Orlando's Veterans Hospital here in Lake Nona. And then we also have Dr. Carbiener, who's an accomplished OBGYN and advocate for women and children on substance abuse. With her offices in Daytona Beach, she has seen a lot of the changes that we've experienced around the state. And she's going to be able to talk to all of us about things that we can do. And Dr. Wohl has a vast amount of experience working in the ER, seeing individuals coming in their moments of crisis. So tonight, we're going to start telling you what you need to know about opioids, addiction, and mental health. So Dr. Wohl, I'll turn it over to you to begin.
And I just really wanted to talk to everyone about why medication-assisted treatment is so vital when we're talking about treating opioid use disorder. Let me start my timer here. And usually I go with a theme of myths versus facts about medication-assisted treatment. It's important to understand that medication-assisted treatment is FDA approved. It's considered the gold standard now proven pharmacologic treatment for opioid use disorder. It's really the backbone of the treatment now. Of course, in addition to that, we want psychosocial counseling and cognitive behavioral therapy and peer support and community support to prevent loneliness and such. But I want to drive home how important medication assisted treatment is. We also call it medication for addiction treatment. So what are opioids? Basically, opioids are legal substances that are often prescribed by a doctor that relieve pain. They can also be illegal substances such as heroin or illicitly made or street-made fentanyl. And these drugs are extremely powerful that create a very strong high. They create a lot of euphoria, and they create a feeling of wellness and serenity. The problem with opioids is that they bind to these sites in our brain and our spinal cord, and that diminishes pain perception, but in high doses, it tells our brain essentially to stop breathing spontaneously, and that causes overdose and death. It's important to understand that addiction is a complex brain disease. Prolonged drug use literally causes rewiring of the brain. Everybody always says, wow, they're just not thinking, you know, they're just making terrible decisions. But they honestly can't help the decisions they're making. They're trying desperately to avoid to avoid withdrawals, which are painful. And so they'll do anything, and they honestly don't use the frontal areas of their brain any longer. The frontal areas of our brain are what tells us, hey, that's not so smart. Maybe you shouldn't do that. Maybe you shouldn't go into this area to get those drugs. Maybe you're going to be caught by the police. They don't think that way because of this rewiring. Once you kind of accept that and accept how much of a disease process it is, it helps us deal with these patients with more compassion. So what do medications do? Medications basically stabilize the patient's brain chemistry and makes them much more susceptible to treatment and therapy. So here's a diagram showing that initially with their initial use, the drug causes euphoria. As they continue to get tolerant to the drug and need more and more of the drug to use, they're using the drug just to get normal. But when they go into withdrawal, they act frantically. These patients will, do anything to get out of withdrawal. And of course, they're not really ready for treatment if they're feeling that way. Any psychosocial treatment or counseling is extraordinarily difficult. And so that's where medication-assisted therapy comes in. It stabilizes that curve and sets them up for much better success. I always state to people that the best definition of addiction, it's very, very simple. Everybody can memorize it. It's continued compulsive use of a substance despite negative social consequences. Some also have been including the fact that it's also associated with dishonesty about the amount and frequency of use. So what are negative social consequences? Well, losing your job is a negative social consequence. Having people state that you're just not acting yourself and you're very withdrawn, that's a negative social consequence. Not treating your child to sort of the parental attention that they deserve is a negative social consequence. Arguments between you and your spouse or significant other or your partner in general, if that's going on because of your use, again, negative social consequence. Getting arrested, obviously negative social consequence. Fired from your job. So folks will continue to use despite those negative social consequences. And why is that so important? Well, it's important because a lot of people use the myth and say that MAT is just replacing one addiction with another. And I always state to everybody in the audience, how many of you think you're addicted to caffeine? And a lot of people will raise their hand, and I argue with them and say, no, you're not addicted to caffeine. You're dependent on caffeine. What does dependence mean? Well, it means that you have to use the drug or else you can get withdrawal. You're physically dependent on it. But what don't you have that addiction does? You do not have those negative social consequences. Whoops. And those are those acquisition harms, the debilitating cravings, the perpetual cycle of high and low, poverty, frantic, manic behavior, and then the injection harms, which is accidental overdose, local infections, or HIV. So we're very comfortable prescribing what is an opioid agonist. That simply means it's an opioid replacement, and it binds to the receptors in our brain that normally bind to our endorphins. Endorphin means endogenous morphine. The word endogenous means from our own bodies. And so that's what these drugs do. They mimic endorphins. So if we prescribe them a drug that stabilizes their brain chemistry and diminishes these negative social consequences, we're very happy that they are dependent on that medication. We're comfortable with that. It's keeping them alive. Many people are dependent on caffeine. Many people are dependent on their insulin for their diabetes or their high blood pressure medications or their antidepressants, and we should treat it just the same. I also want everybody to realize that starting in 2019, we started to say that recovery did not mean abstinence. It's okay that people are continuing to use. We simply want a process of change where people are improving their health and wellness and living self-directed lives. Remission or recovery, therefore, should not be taken to mean complete cessation or stoppage of opioid misuse. Instead, we should just acknowledge that any reduction is a worthy goal. It's also what we're trying to do as addiction treatment providers nowadays. We don't kick people out of treatment if they come up positive for cocaine or marijuana. We counsel them more and offer them more resources. Again, using compassion, understanding the severity of this as an illness and a continually relapsing illness as well. Relapse meaning going back to drug use. And you know, a lot of illnesses oftentimes relapse. Asthma relapses. You know, people with heart attacks, they get chest pain after their stents are placed, these coronary artery stents. They come back to the emergency department a lot of times with chest pain, and yet we don't really stigmatize those patients and say, geez, this treatment doesn't work, we should abandon it. No, we rehash it out. We start another therapy, or we use another strategy to treat the patient. And that's how we should treat addiction or opioid use disorder. Again, everybody's sort of, the stigma used to be MAT is a bad moral choice, and it's inferior to complete unassisted abstinence. I'm telling you today that abstinence rarely works. Almost 90% of patients relapse when they try abstinence for opioid use disorder. And because what Amber mentioned, fentanyl has completely changed the game. If an alcoholic or a person who's suffering from alcohol use disorder relapses and uses alcohol, very rarely could they hurt themselves with that relapse. However, when you have the alternative to a patient who is not receiving MAT is not a drug-free patient. Rather, it's a continually relapsing patient, and relapse has a high association with death. And so why is that? It's because fentanyl is so powerful, these patients will relapse, go onto the street to obtain their drugs, and inadvertently harm themselves with an overdose. This is somewhat of a busy slide. I just want everybody to understand that this is the gold standard. Medication-assisted treatment is the gold standard of treatment. This is the National Academies of Science. These are 1,200 experts that are non-for-profit. They don't have any financial claims to any of the drug companies. And these folks got together in 2019, March of 2019, to determine some conclusions on the use of medications for opioid use disorder. And I just want to read this one, number 6, the most. MAT is effective across all treatment settings studied to date, withholding or failing to have available all classes of these FDA-approved medications for the treatment of those suffering from opioid use disorder in any healthcare or criminal justice setting is denying appropriate medical treatment. What does that mean? In medicine, that means that you're creating substandard care if you're trying to treat a patient with addiction without these medications. Can you force these medications on people? Absolutely not. That would be unethical. But what I'm trying to get across to you as family members and those interested in treating those with addiction from opioids is if you are looking for treatment for them, please find an addiction treatment facility that utilizes MAT. Because if they're not offering you MAT, then in all sincerity, they're denying you appropriate medical treatment. Why do we use these medications? Well, MAT makes the recovery process much safer. There's a lot less chance of relapse. Addiction involves real physical changes in the brain, and we're treating those changes with these medications. 80% of patients show a decrease in illicit drug use. That means street drugs and crime. And then most importantly, I got to highlight 50 to 60% decrease of all-cause death rate. That means that if you suffer from opioid use disorder and I just get you on that medication, I have diminished your chance of death by 50 to 60%. That's absolutely fascinating in medicine today. There's no such treatment that diminishes fatality for stroke, heart disease, cancer by 50 or 60%. But yet we have these medications that can treat addiction, and we're not offering them because of lack of knowledge and many times the stigma surrounding this treatment. This is a really quick table showing you the effectiveness of treatment with medications for opioid use disorder, or MAT. And this number means what percentage of patients stayed in treatment for a year. 74 to 80% stayed in treatment for a year with methadone, 60 to 90% with buprenorphine, and that's also known as Suboxone. And then only 10 to 21% stayed in treatment with naltrexone, which is Vivitrol. That's the long-acting injectable that blocks medications, other opioids. I just want to focus on the bottom here. Understand that, well, the middle here, these medications prevent withdrawal, as I mentioned numerous times, normalize bodily functions, stabilize your brain chemistry. Most importantly, if they are dosed correctly, they do not impair functioning, and there's no negative effect on intelligence, mental capability, physical functioning, or employability. And part of our sort of consortium with business leaders is to get them to understand that these medications, you can hire these patients when they're on these medications. I have a very successful case of a young man who's now a lineman, climbing up telephone poles and working with high-powered lines, and he's on buprenorphine. The three medications, I'm just going to quickly run through them. Naltrexone, that's also known as Vivitrol. That's an injectable drug that blocks all opioids. And then methadone acts, it is a full opioid. It works at the receptors the same way that any other opioid drug does. But patients have to come back to the clinics every day to receive their treatment, and that can mean long, burdensome lines, odd hours, and that can really mess with your life or caregiving responsibilities. And so enter, buprenorphine. Buprenorphine is a drug that was designed for in-office use. It is much safer than any other opioid. It binds to these pain receptors so strongly that if you use another opioid while you're on buprenorphine, that other opioid won't work very well because buprenorphine is taking up the site. So therefore, it's less abuse prone and it's much more safe. Patients can take the medication home, unlike methadone, and dose it themselves because it's very, very safe from overdose. It's also very safe in pregnancy as well. You can see in France, when they increased buprenorphine prescriptions, heroin overdoses dropped significantly. They repeated a similar study in Baltimore, Maryland, and had many of the same results. Heroin overdoses dropped significantly when they increased access to buprenorphine. And so one of the last things I want to mention is a lot of people have the impression that these medications should only be used for a short period of time. Oh, they should only be on it for 3 to 5 months is what I always hear. That is absolutely not true. That's not what the science says. The science says we need to destigmatize our idea of these patients using this medication. Do we say, hey, patients who have diabetes only need insulin for 3 to 5 months? No. There's absolutely no evidence that supports stopping MAT early. And most of the studies say you need MAT for 1 to 2 years to have the greatest rate of long-term success. Some patients could need it indefinitely. And many others, the National Institute on Drug Abuse, NIDA, says 12 months of treatment is the minimum. Now, if a patient is undergoing MAT treatment and they have excellent counseling and they figure out ways to develop a lot of emotional resilience and get away from those triggers that trigger them for relapse, then and only then should that patient consider possible abstinence and a slow taper from these medications. So you'll also hear, in addition to medications for addiction treatment, you'll hear harm reduction. What is harm reduction? Harm reduction is strategies that are aimed at reducing the negative consequences associated with opioid abuse and addiction. What does that mean? It means that we know that many patients are going to go back and use. We know that they're going to fail treatment, and we want to empower them. A lot of people say, well, you're encouraging their use. And I always say, no, I'm not encouraging it. I'm empowering them to use safely. I know they're going to use. It's much like Mothers Against Drunk Driving when they determined that we should all use a designated driver. Basically, MAD, or Mothers Against Drunk Driving, said, we know that people are going to drink and drive. And so let's encourage a harm reduction strategy of getting persons to use a designated driver. And what are harm reduction strategies? Well, in the emergency department, I actually teach people how to safely inject. Do I sit there and carry it out and do it? No, I do not. But I tell them not to use alone. I tell them to use naloxone, use tester shots. I explain to them how much they need to clean their skin if they're going to inject. And why do I do this? Because number one, it's my job as a physician to keep people healthy, to preserve human life. That's my oath. And if educating them on using safely preserves their life and prevents them from getting HIV or hepatitis C or a terrible heart valve infection called endocarditis, then I'm very proud of these efforts. You will see in a number of other cities, and I don't necessarily encourage this for Florida, but you will see needle exchange programs to give patients safe needles, because again, they are going to use, when they go to these needle exchange programs, they have care providers who can also get them into treatment. And so it's a good, safe place for these patients. The other issue with harm reduction strategies is naloxone distribution. We've all heard of naloxone. It's the antidote to overdoses. It will quickly reverse an overdose. And it's very important to know that any doctor can provide a prescription for naloxone to any person that is witnessing or potentially could witness an overdose. That means if you're a husband, brother, sister, mother, father of an opioid user or an opioid use disorder patient, you can request naloxone. It's also available via a standing order. For Project Opioid, I have written a standing order to educate patients or persons and then get them naloxone in their hands. It's also available without a prescription or this standing order prescription at CVS Pharmacy. You still need a prescription, but one physician can write a standing order and say, hey, if the pharmacist does this and educates the patient, they can go home with naloxone. This is what naloxone looks like. The little box even has instructions on it. But quickly, I'll just tell you as non-clinical, non-healthcare providers that the signs of an opioid overdose are shallow or slow breathing, blue lips or cold and clammy skin. Sometimes patients will vomit. They are very difficult to arouse, or they're not responsive when they're sleeping. They cannot be woken. And sometimes you might even hear gurgling or rattling snoring. And so I encourage you to first administer Narcan. You cannot hurt a person if they are not on opioids and you give them Narcan. It's not harmful to that patient. So any patient, frankly, that you find passed out nowadays should probably get a dose of Narcan and then immediately call 911, lay that person on their side, and consider rescue breathing or chest compressions until EMS arrives. So the take-home points are that opioid use disorder is a treatable brain disease. Opioid use disorder is unique in that relapses are often fatal because of the potency of fentanyl. Medications for addiction treatment are effective, save lives, and should be available to every opioid use disorder patient. And withholding these drugs is denying appropriate medical treatment. And as family members or interested parties, we need to break down the barriers to obtaining medication-assisted treatment in our community. Thank you so much. I appreciate your attention, and I'm going to hand it back to Amber.
Thank you so much, Dr. Wohl, for that amazing information. And as a doctor, I'm very grateful to have you here and have the information that you've shared with everyone on this webinar. I would like to reiterate a little bit about Narcan. It is my job to get Narcan out to the community, as Dr. Wohl stated, through that standing order. But I'm going to take a second and I'm going to really break down what Narcan does and why it is such a vital medication, life-saving even, that everyone should have in their glove compartments of their cars, in their medicine cabinets at home, in their first aid kits at their places of work or worship. So as Dr. Wohl stated, Narcan responds to the same areas of the brain that opioids respond to. Think of it like a magnet. An opioid has a strong connection to your receptors in your brain, well, your brainstem, and a long-lasting effect. Narcan has a much stronger magnetic connection. So it kicks the opioid off, and it can effectively turn off everything that that opioid was doing. And so that opioid blocks all of your pain or sensations and other things that we tie into this dependency. And so once you administer Narcan, it completely shuts it off. That's going to be jarring. So if you administer it to someone, you will likely see within 30 to 90 seconds, or maybe a little more if they've taken a lot. Once they become awake, it's going to be a shock because they're instantly going to feel every sensation that was muted by those opioids. So again, I know Dr. Wohl showed you pictures, but sometimes it's really good to see. Right here we have Narcan. When you open up the little front sleeve, it does give you those directions. They do sound and look really kind of ominous, scary, and overwhelming, but this is such a simple medication to use. You open the box. If someone you know or love is experiencing an overdose, you want to first make sure, like with most medical situations, they're in a space where they can't hurt themselves. Lay them down, turn them on their side in case they vomit so they don't choke, and make sure you have their airways as clear as you can. When you pull Narcan out of the box, it's going to come in two little containers like this. Kind of looks like Flonase or any kind of nasal spray. So what you do is you use it like a little plunger, like this, and you put it in their nostril and you just squeeze. And then you wait. If they don't wake within 30 to 60 seconds, maybe 90, go ahead and give them a second dose. If you know this person and you know they might be using opioids on a regular basis, they may need even more than that, especially now with fentanyl. Fentanyl being so much stronger than traditional opioids or heroin, if you will. And they may need more Narcan. So once you squirt it up their nose, once they wake up, you want to make sure you're already calling 911 because this doesn't completely stop what those opioids are doing. It kicks them off for a moment at time. But you know what happens when you have a stronger magnetic connection? You have a shorter half-life. So while this is stronger to your receptors in your brain than opioids, it has a shorter lifespan, which means After about 20 to 90 minutes, again, depending on a couple factors like your body composition, your extended opioid use, or how much opioids are in your system, will kind of vary how long that you will be out of this overdose. If there is a lot of opioids in your system, you could fall right back into that overdose. And so you really have to make sure that you are calling 911 and that you are getting that individual to the ER as quickly as possible, because they still need access to those emergency medical services. What this does is give you time. It saves their life so that they have another chance to make a different decision. Now, I know Dr. Wohl talked quite a bit to you guys about how Narcan is available through standing orders at pharmacies by prescription from your doctors. And again, oh, sorry, let me chime in here. I had someone from the audience make a point to say that if there's no response within 2 to 3 minutes, try again. You are so right. Use more Narcan. You can't use enough of this stuff. It will do no harm to anyone. If there are not opioids in your system, it cannot do anything to you. It will not cause you pain. It is a safe medication that only reacts when it interacts with opioids in your system. So like that lovely participant stated, keep using it until they revive them, until they are revived. And again, make sure you're calling 911 and getting emergency services there. So I'll digress and return back to the availability of Narcan has been a hot issue in our communities. It's so fantastic that legislation and change within the medical community is really bringing Narcan out in droves, but there's still a lot of barriers for individuals. Costs can be high, or they don't understand the medication, and so they don't get it with their prescription. So organizations like Project Opioid provide Narcan at no cost, completely free to anyone who needs it. And it's not just us. There are amazing organizations around the state. By visiting isaveflorida.com, or forgive me, it might be .org, you can see organizations all around the state that provide Narcan. And if you need it, we're here to give it to you. So please visit projectopioid.com/get Narcan if you need Narcan. Or if you're a Central Florida local, come find us. We're in downtown. We'll get you Narcan. Money shouldn't be the thing that holds you back from saving your loved one's life. Give them a chance to seek help. So as I digress, I would like to welcome to the floor Dr. Pamela Carbiener so she can talk a little bit more with us about opioid abuse and mental health, and especially with how that can impact women and children. So Dr. Carbiener, I will let you take over.
Thank you very much, Amber. And what I would first like to say is thank you for the privilege of being able to talk to everybody about this issue. You may be wondering why, as an obstetrician in the community, this became such a passion for me. And in a couple of minutes, I just want to give that history because I think it'll help people understand how I came about this. Then I know you wanted me to talk about the vulnerable populations out there, about treatment, and what is recovery in this population in the trenches. And it started out about 2010 when I was working for high-risk clinic, high-risk prenatal clinic for the Department of Health, when my population changed almost entirely from being a broad high-risk population to women with substance use and opiate use disorder. And I thought that there was something uniquely wrong with Volusia County and east coast of Florida, and learned later on that this was a national issue. Healthy Start at that time, which is a wonderful group that networks in every county for women and young babies, arranged a caseworker to work with me on a day-to-day basis in the health department. And it created a wonderful opportunity for a physician and then a case manager to address the needs of these people. Because frankly, listening to a baby's heartbeat and measuring a mother's tummy meant nothing when she was going back to live in a car and shoot up heroin 6-7 times a day. When the health department divested from treating pregnant women, I was forced out of basically a morality to bring these women into my private practice. But there I did not have the other sources of help, the other support systems. And it became so overwhelming that I was ready to stop doing this care for pregnant women who had opioid use disorder. Then as our communities in the state started to come together, much like Project Opioid and targeted case management from Medicaids and other service organizations, we started looking at this as a group and how to handle it. Because before COVID, I used to say that the opioid epidemic was the epidemic of our times, like bubonic plague in the 1300s or influenza in the early 1900s. But the epidemic is of pain and despair. And the opioid use was simply just a symptom. And as we move forward, we're seeing it change from the pills to the heroin to the fentanyl. And it's a moving target because what we have to treat is the pain and the despair. And physicians can't do that on their own, but they can start. And one of the things is recognizing those multiple vulnerable populations. And pregnancy is a time in somebody's life where they don't expect to be having a baby while being addicted. But because young women are part of our general population and the general population is at risk for opioid use disorder, they have increased in the amount of numbers of women who are enduring this and dealing with it during pregnancy. I'm going to share my screen and show a couple slides here, see if we can get them up. Basically, this is to support what Dr. Wohl said. In our country right now, greater than $700 billion a year in increased costs to the medical healthcare system is due to substance use. And it is involving up to probably at this point, 24 to 26 million Americans. It's more than equal to the number of diabetics. It's 1.5 times more than the number of people with cancer. And these people will average 8 times more in healthcare costs due to the disproportionate and inefficient use of our system. And yet it's a disease. It's a primary chronic relapsing disease of the brain. And we treat it like it is a choice. We treat it like it is something that people have a personality flaw or character weakness. And the challenge for me is caring for pregnant women in active addiction and in recovery. And this is a daunting slide to look at, but it's what I deal with on a daily basis. 5.4% of pregnant women report illicit drug use in the country. And I would say in Florida, it's probably 10% or more. And it remains the most commonly misdiagnosed and undertreated diagnosis among pregnant women with the most profound outcomes. Issues facing pregnant drug users and their children are exposure to violence and trauma, the loss of generational support because of generational drug use, the loss of productivity and the ability to become the person they want to be through losing of the ability to have a formal education and get the good jobs that those educations will provide. So you see people that get involved with the law, and then health-wise, you see them develop multiple drug exposures with those impacts. They don't learn how to parent. Their children develop significant trauma as young people. Multiple psychiatric issues can then develop, and these people have dual diagnoses. Because they can't afford to have healthy homes and healthy environments, these children are often in unstable housing. And with a lack of positive and supportive relationships, food insecurity, neglect, we get despair, we get pain. And what better way to try and deal with despair and pain is to make yourself numb. And that is essentially how I see the opioid crisis. And this slide here, it's a little out of focus, but it's a terrifying slide because it shows people what I think is the greatest fear faced by parents, grandparents, and siblings of what can happen when a family loses their structure and addiction becomes over the overall focus of these young people. And what's interesting is that opioid addiction has a greater impact on women than on men. It appears to have a greater impact on people of lower socioeconomic status and disparate populations. And it's not so much the physiology, although there is definitely a gender issue there. A lot of it has to do with the economics. But the rate of opioid-related overdoses increased almost 500% among women compared to 220% in men. And heroin doses by 2015 had risen more than twice in women than it had in men. And women become dependent upon these opioids in much smaller doses and in a much shorter time frame. And risk factors for women are much more likely to include psychological and emotional stress. Florida's opioid epidemic is insane. From 1999 to 2010, we saw over 400% increase in deaths. And by 2016, we ranked third in the country for overdose from opioids in women, following Ohio and New York. And the incidence of infants being born dependent upon opioids and then withdrawing from opioids, called neonatal abstinence syndrome, increased sixfold. Pregnancy so often can be an entry point to treatment for a substance use disorder if we can get rid of the stigma and if we can incorporate the risk reduction that Dr. Wohl talked about. If we can recognize that we need to embrace these women, they can come to us through prenatal care, through the court system, through the jail, through detox. And what is important is that regardless of their point of entry, that they are given compassion, that they are given the time to learn what options are available, that those people involved meet them where they are at and not try to fit a round peg into a square hole. And that we tell them that treatment will minimize the risk of neonatal abstinence disorder. And what's very important for a lot of women who are scared to get prenatal care is that they're afraid that the doctor will fire them from the practice. And in all honesty, that does happen. And we need to implore and engage that our OBGYN physicians become opioid use disorder trained, that they understand the benefits of buprenorphine in pregnancy, which has a negligible neonatal abstinence syndrome as compared to, say, methadone or many of the street drugs. These doctors need to recognize that this is an opportunity to give a woman to recover. No woman wants to be a pregnant person in addiction. They all want to protect their baby. They are just involved in a disease that has hijacked their brain and they need our help. Abstinence-based therapy in pregnancy invites overdose from relapse. And one of the worst things that can happen to a baby in the womb is the constant high dose, then no dose, then a low dose, then no dose, then a high dose. A stable dose of legal opioids given in a safe manner that avoids acute bacterial endocarditis or sepsis or overdose is our goal. What I tell my patients is anything but the needle. And it is so important that we give them that compassion. I think that if doctors truly recognized that this is something we are morally obligated to address, and if every OBGYN physician out in the community would simply begin to prescribe buprenorphine, become comfortable with it, prescribe to less than 30 patients at a time, they will not have to worry about X waivers. It is legal, it's appropriate, it's safe, it is mandatory, in my opinion. And those physicians need to be able to network with such groups like Project Opioid and the Florida Perinatal Quality Collaborative and DCF and other entities in our communities that all want the same goal: healthy moms, delivering healthy babies, and being able to keep those children and become healthy families. And I would be happy to take any questions about that. It is something that is near and dear to my heart. And so, Amber, do you want to have any questions entertained?
Yes, I actually have a few questions for both you or Dr. Wohl, whomever is prepared to answer. If you are finished with your slides, Dr. Carbiener, it'd be great if you could exit screen sharing. If I am injured and for any reason, and I go to the doctors and they want to prescribe me a pain medication, what should I do as a patient to take ownership over my medical health? Should I be talking about particular types of medicines? Should I be researching?
Dr. Carbiener, do you mind if I try and answer that one up front?
Please go ahead.
I think that's an awesome question, because a lot of times I believe that, patients can take on a bit more responsibility. That's not to be said in a smart way at all. I hope you guys know I'm not smart when dealing with patients. But, patients are very educated nowadays, and they look a lot of things up, and they come into the emergency department, and basically, we have a pretty good discussion about their options because of what they've seen and looked up. And yet, when it comes to pain medication, I would say that most people treat their pain the wrong way. Everybody kind of goes first for the Vicodin or the Percocet. And I promise you, I had a pretty significant motorcycle accident and had essentially third-degree burns on parts of my body, and I never took an opioid. I used higher dose non-steroidal anti-inflammatories, so that is regular old Advil. And Advil, taken at about 600 milligrams, that's 3 tablets, 3 to 4 times a day, really diminishes your need for opioids. Now, I have to make a disclaimer. Patients with kidney dysfunction or patients with the potential to develop stomach ulcers, or patients who are on anticoagulant medication like Coumadin, are not really good candidates for that medication. But a broad swath of patients can take Advil. If you take it in conjunction with 1,000 milligrams of Tylenol, and the 1,000 milligrams of Tylenol is every 6 hours, again, the literature shows that people really don't need their opioid pain medication. I always say to people, keep those patients that are opioid naive. We don't need, a 17-year-old experiencing what it feels like to be on Vicodin or Percocet for their wisdom teeth removal.
Mhm.
We need to change our idea as a culture of what constitutes acceptable levels of pain. So when we're teaching now, we don't give a pain scale and say, oh, you should have 0 pain. That's what the pharmaceutical companies pushed us to. You should have some pain, and you should be able to function with your pain. So we describe it in a functional manner. And so really it's your responsibility as the patient to, talk to your doctor about other options and what can you use outside of opioids. Now, if you have 6 to 10 tablets of opioids, that's probably okay if you're post-surgical and you use them within the first 3 days post-surgery. The research has shown that most patients, about 75% of patients, don't use opioids after the first 3 days. And we've shown that if you use opioids for 5 to 7 days, you sort of increase your chances of long-term use significantly. So the magic number is less than 3 days. The other treatment is Advil and Tylenol, frankly. Exercise, staying mobile, and frankly, dealing with some degree of pain and changing your expectations on your level of pain. I don't know if Dr. Pam has anything to add, but that's my...
That is a very appropriate and important discussion to be having with everybody who is opioid naive. And we should be doing our best as physicians and healthcare workers to keep people opioid naive. Where it does become problematic is when you have people who have a history of being on opioids and they're tolerant, either from legal use or street use. And let's say that they are on MAT therapy, or that they're in abstinence, or that they simply have a family history of use disorder and have not yet gone down that path, but know that they don't want to. We need to listen to them when they say they want to avoid opioids in their surgical and obstetrical treatment, and do our best to recognize how we need to counsel them about reasonable amounts of pain and how to endure that and how to avoid opioids. One of the biggest problems is when they are having hyperalgesia, because the brain is a cruel taskmaster. The opioid, basically, the locums, the cerealis, was it the cerealis accumbens? And, it can make your body feel great pain if you don't give that portion of your brain what it wants. And we have to help these people work through that with Tylenol, with nonsteroidals, with lidocaine, and do things in surgery that reduce people's pain for the post-operative, like putting lidocaine at every level, doing tap blocks, which help promote long-term pain, minimal pain after surgery. There are many things that we can do, and we are trying to do in our obstetrical units and gynecologic units, so that when we do surgery, when people do have deliveries, when they're in painful situations, we don't put them at risk for either having a new opioid dependency or revisiting one that was created in the past.